Welcome to Crazy Nurse RN Hub, where learning becomes a tradition. Come, join me as we explore the multifaceted world of nursing. Hi there, student nurses. My name is Crisolmer Ducanes, clinical instructor, teaching fundamentals of nursing practice. Today, we'll be talking about the nursing process. Lydia Hall originated the term nursing process in 1955, and Johnson 1959, Orlando 1961, and Weidenbach 1963. They were among the first to use it to refer to a series of phases describing the practice of nursing. Since then, various nurses have described the process of nursing and organized the phases into different ways. The use of the nursing process in clinical practice gained additional legitimacy in 1973 when the phases were included in the American Nurses Association Standards of Nursing Practice. The nursing process is a systematic, rational method of planning and providing individualized nursing care. The purpose of nursing process are to identify a client's health status and actual or potential healthcare problems or needs. Also to establish plans to meet the identified needs of the client. And lastly, to deliver specific nursing interventions to meet the identified needs of the client. So who are our clients? It may be an individual, a family, a community, or a group of people. Now let's proceed to the characteristics of the nursing process. The nursing process has distinctive characteristics that enable the nurse to respond to the changing health status of the client. These are, first, is cyclic and dynamic in nature. Data from each phase provide input into the next phase. Findings from the evaluation phase feedback into assessment. Hence, the nursing process is a regularly repeated event or sequence of events or a cycle that is continuously changing, which means it's dynamic, rather than staying the same or static. Next is client-centeredness. The nursing process is client-centered. The nurse organizes the plan of care according to client problems rather than nursing goals. Next, it focuses on problem solving and decision making. The nursing process is an adaptation of problem solving and systems theory. It can be viewed as parallel to but separate from the process used by the physicians, also known as the medical model. Both processes begin with data gathering and analysis, based action, interventions, or a treatment on a problem statement, which could either be nursing diagnosis or medical diagnosis, and include the evaluative component. However, the medical model focuses on physiological systems and the disease process, whereas the nursing process is directed toward a client's responses in real or potential disease and illness. Decision making is involved in every phase of the nursing process. Nurses can be highly creative in determining when and how to use data to make decisions. Next is interpersonal and collaborative style. The nursing process is interpersonal and collaborative. It requires the nurse to communicate directly and consistently with clients and families to meet their needs. It also requires the nurses collaborate as members of healthcare team in joint effort to provide quality client care. Next is universal applicability. The universally applicable characteristic of the nursing process means that it is used as a framework for nursing care in all types of healthcare settings, with clients of all age groups. Next is the use of critical thinking. Nurses must use a variety of critical thinking skills to carry out the nursing process. And lastly, we have the clinical reasoning. Nurses must utilize clinical reasoning throughout the delivery of nursing care. By reflecting, the nurse determines whether the outcome of care was appropriate. Now we have the 5 phases of the nursing process. We have your assessing, diagnosing, planning, implementing, and evaluating. Now let's have assessing or the assessment phase. Assessing is the systematic and continuous collection, organization, validation, and documentation of data or information. It is a continuous process carried out during all phases of the nursing process, and it is to establish a database about the client's response to health concerns or illness and the ability to manage healthcare needs. There are types of assessment. First is initial assessment. It is performed within specified time after admission to a healthcare agency. It is to establish a complete database for problem identification, reference, and feature comparison. Example of this is the nursing admission assessment. We also have your problem-focused assessment. It is an ongoing process integrated with nursing care. This is to determine the status of a specific problem identified in an earlier assessment. Examples of this are early assessment of client's fluid intake and urinary output in an intensive care unit. Also, an assessment of a client's ability to perform self-care while assisting a client to bathe. Next is the emergency assessment. During any physiological or psychological crisis of the client. This is to identify life-threatening problems and also to identify new or overlooked problems. Examples are rapid assessment of an individual's airway, breathing status, and circulation during a cardiac arrest. Also, an assessment of suicidal tendencies or potential for violence. Lastly, we have the time-lapse tree assessment. It is done several months after initial assessment. It is to compare the client's current status to baseline data previously obtained. Reassessment of a client's functional health patterns in a home, care or outpatient setting, or in an hospital or at shift change. So this is an example of your time-lapse tree assessment. Now let's proceed to the data collection. It is the process of gathering data or information about a client's health status. Data collection must be both systematic and continuous to prevent the omission of significant data and reflect a client's changing health status. Now let's discuss about database. Database contains all the information about a client. It includes the nursing history, physical assessment, primary care provider's history and physical examination, results of laboratory and diagnostic tests, and material contributed by other healthcare personnel. Now let's proceed to the types of data. First is subjective data, also referred to as symptoms or covert data. These are apparent only to the person affected and can be described or verified only by that person. Itching, pain, and feelings of worry are examples of subjective data. Subjective data include the client's sensations, feelings, values, beliefs, attitudes, and perception of personal health status and life situation. We also have the objective data, also referred to as signs or overt data, are detectable by an observer or can be measured or tested against an accepted standard. They can be seen, heard, felt, or smelled, and they are obtained by observation or physical examination. For example, a discoloration of the skin or a blood pressure reading is an objective data. During the physical examination, the nurse obtains objective data to validate subjective data and to complete the assessment phase of the nursing process. Now let's discuss about sources of data. Sources of data are primary and secondary. When we say primary source, the client themselves are the primary source of the data, which is considered as the best source of the data. We also have the secondary or indirect source. Family members or other support persons, other health professionals, records and reports, laboratory and diagnostic analysis, and relative or related literature are secondary or indirect sources. In fact, all sources other than the client are considered secondary sources. All data from secondary sources should be validated if possible. Now let's proceed to the data collection method. The principal methods used to collect data are observing, interviewing, and examining. Observing occurs whenever the nurse is in contact with the client or support persons. Interviewing is used mainly while taking the nursing history. Examining is the major method used in the physical health assessment. In reality, the nurse uses all three methods simultaneously when assessing clients. For example, during the client interview, the nurse observes, listens, asks questions, and mentally retains information to explore the physical examination. Now let's discuss about observing. To observe is to gather data by using the senses. Observing is a conscious, deliberate skill that is developed through effort and with an organized approach. Although nurses observe mainly through sight, most of the senses are engaged during careful observations. Observing has two aspects. First, noticing the data, and selecting, organizing, and interpreting the data. A nurse who observes that a client's face is flushed must relate that observation to findings such as body temperature, activity, environmental temperature, and blood pressure. Errors can occur in selecting, organizing, and interpreting data. For example, a nurse might not notice certain signs, either because they are unexpected or because they do not conform to preconceptions about a client's illness. Nurses often need to focus on specific data in order not to be overwhelmed by a multitude of data. Observing, therefore, involves distinguishing data in a meaningful manner. For example, nurse caring for a newborn learn to ignore the usual sounds of machines in the nursery, but respond quickly to an infant's cry or movement. Next is interviewing. It is a planned communication or a conversation with a purpose. For example, to get or give information, identify problems of mutual concern, evaluate change, teach, provide support, or provide counseling or therapy. One example of the interview is the nursing health history, which is a part of the nursing admission assessment. In a focused interview, the nurse asks the client specific questions to collect information related to the client's problem. This allows the nurse to collect information that may have previously been missed and yields more in-depth information. There are two approaches to interviewing. We have the directive interview and the non-directive interview. When we say directive interview, it is highly structured and elicits specific information. The nurse establishes the purpose of the interview and controls the interview at least at the outset. The client responds to questions, but many have limited The client responds to questions but may have limited opportunity to ask questions or discuss concerns. Nurses frequently use directive interviews to gather and to give information when time is limited. By contrast, during non-directive interview, also known as rapport building interview, the nurse allows the client to control the purpose, subject matter, and pacing. When we say rapport, it is an understanding between two or more people. A combination of directive and non-directive approaches is usually appropriate during the information gathering interview. The nurse begins by determining areas of concerns for the client. If, for example, a client expresses worry about surgery, the nurse pauses to explore the client's worry and to provide support. Simply noting the worry without dealing with it can leave the impression that the nurse does not care about the client's concerns or dismisses them as unimportant. Now let's have the types of interview questions. We have the closed questions and open-ended questions. When we say closed questions, it is used in the directive interview, and these are restrictive and generally require only yes or no or short factual answers that provide specific information. Closed question often begins with when, where, who, what, do, or is. Examples also are: what medication did you take? Are you having pain now? Show me where it is. How old are you? When did you fall? Closed questions are often used when information is needed quickly, such as in an emergency situation. The highly stressed person and the person who has difficulty communicating will find closed questions easier to answer than open-ended questions. On the other hand, open-ended questions are associated with a non-directive interview. It invites clients to discover and explore, elaborate, clarify, or illustrate their thoughts or feelings. An open-ended question specifies only the broad topic to be discussed and invites answers longer than one or two words. Such questions give clients the freedom to divulge only the information that they are ready to disclose. The open-ended question is useful at the beginning of an interview or to change topics and to elicit attitude. Here are also the types of interview questions. It could either be neutral question or leading question. When we say neutral question, it is a question that the client can answer without direction or pressure from the nurse. It is open-ended and it is used in non-directive interviews. Examples are: how do you feel about that? What do you think led to the operation? A leading question, by contrast, is used for closed questions, and it is used in a directive interview and thus directs the client's answers. Examples are: you're stressed about surgery tomorrow, aren't you? You will take your medicine, won't you? The leading question gives the client less opportunity to decide whether the answer is true or not. Leading questions create problems if the client, in an effort to please the nurse, gives inaccurate responses. This can result in inaccurate data. Now let's have the stages of interview. An interview has three major stages: the opening or introduction, the body or development, and the closing. The opening is the most important part of the interview because what is said and done at the time sets the tone of the remainder of the interview. The purposes of the opening are to establish rapport and orient the interviewee. The body. In the body of the interview, the client communicates what he or she thinks, feels, knows, and perceives in response to questions from the nurse. Effective development of the interview demands the nurse to use communication techniques that make both parties feel comfortable, and serve the purpose of the interview. Lastly, we have the closing. The nurse terminates the interview when the needed information has been obtained. In some cases, however, a client terminates it, for example, when deciding not to give any more information or when unable to offer more information for some reasons. The closing is important for maintaining rapport and trust and for facilitating future interactions. Now let's proceed to examining. The physical examination or physical assessment is a systematic data collection method that uses observation, such as sense of sight, hearing, smell, and touch to detect health problems. To conduct the examination, the nurse uses techniques of inspection, auscultation, palpation, and percussion. The physical examination is carried out systematically. It may be organized according to the examiner's preference in a head-to-toe approach or a body systems approach. Usually, the nurse first records a general impression about the client's overall appearance and the health status. For example, age, body size, mental and nutritional status, speech, and behavior. Then the nurse takes such measurements such as vital signs, height, and weight. The cephalocaudal or the head-to-toe approach begins the examination at the head, progresses to the neck, thorax, abdomen, and extremities, and at the ends at the toes. The nurse, using a body system approach, investigates each system individually, that is, the respiratory system, the circulatory system, the nervous system, and so on. During the physical examination, the nurse assesses all body parts and compares findings on each side of the body. Now let's proceed to the screening examination. It is also called as the review of systems, and it is a brief review of essential functioning of various body parts or system. An example of a screening examination is the nursing admission assessment form. Now let's proceed to organizing data. The nurse uses a written or electronic format that organizes the assessment data systematically. This is often referred to as nursing health history, nursing assessment, or nursing data form. The format may be modified according to the client's physical status, such as one focused on musculoskeletal data for orthopedic clients. Data can be organized through body systems model, Maslow's hierarchy of needs, developmental theories, wellness models, Gordon's functional health pattern framework, Orem's self-care model, and Roy's adaptation model. Now let's proceed to validating data. When we say validation, it is the act of double-checking or verifying data to confirm that it is accurate and factual. We have also cues, which are subjective or subjective data that can be directly observed by the nurse. And when we say inferences, these are the nurse's interpretation or conclusions made based on the cues. Lastly, we have documenting the data. Accurate documentation is essential and should include all data collected about the client's health status. Data are recorded in a factual manner and not interpreted by the nurse. A judgment or conclusion, such as appetite good or normal appetite, may have different meanings for different people. To increase accuracy, the nurse records subjective data in the client's own words using quotation marks. Restating, in other words, what someone says increases the chance of changing the original meaning. Now let's talk about diagnosing. Diagnosing is the second phase of the nursing process. In this phase, nurses use critical thinking skills to interpret assessment data and identify client strengths and problems. Diagnosing is a pivotal step in the nursing process. Activities preceding this phase are directed towards formulating the nursing diagnoses, the care planning activities, following this phase are based on the nursing diagnoses. Now let's discuss NANDA International, or the North American Nursing Diagnosis Association. International recognition came with the first Canadian conference in Toronto in 1977 and the International Nursing Conference in May 1987 in Calgary, Alberta, Canada. In 1982, the conference group accepted the name North American Nursing Diagnosis Association, or NANDA, recognizing the participation and contributions of nurses in the United States and Canada. In 2002, the organization changed its name to NANDA International to further reflect the worldwide interest in nursing diagnosis. The purpose of NANDA International is to define, refine, and promote a taxonomy of nursing diagnostic terminology of general use to professional nurses. So what is taxonomy? It is a classification system or set of categories arranged based on a single principle or set of principles. The members of NANDA include staff nurses, clinical specialists, faculty, directors of nursing, deans, theorists, and researchers. The group has currently approved more than 200 nursing diagnosis labels for clinical use and testing. To use the concept of nursing diagnosis effectively in generating and completing a nursing care plan, the nurse must be familiar with the definitions of terms used and the components of nursing diagnosis. First, let's define what is diagnosis. It is a statement or conclusion regarding the nature of phenomenon. The standardized NANDA names for the diagnosis are called diagnostic labels, and the client's problem statement, consisting of the diagnostic label plus etiology, which is the causal relationship between a problem and its related or risk factors, is called a nursing diagnosis. The official NANDA definition of nursing diagnosis is a clinical judgment concerning a human experience or response to health conditions or life processes, or a vulnerability for that response by an individual, family, group, or community. A nursing diagnosis provides the basis for selection of nursing interventions to achieve outcomes for which the nurse has accountability. Professional nurses or registered nurses are responsible for making nursing diagnoses, even though other nursing personnel may contribute data to the process of diagnosing and may implement specific nursing care. The American Nurses Association, Nursing Scope and Practice of Nursing, states that nurses are accountable for analyzing data to determine diagnoses or issues. The standard also specifies that nurses should use standardized classification systems when naming diagnoses. The domain of nursing diagnosis includes only those health states that nurses are educated and licensed to treat. For example, generalist nurses are not educated to diagnose or treat diseases. This task is defined legally as within the practice of medicine. Yet, nurses can diagnose and treat deficient knowledge, ineffective coping, or imbalanced nutrition, all of which are the human responses to the medical diagnosis. A nursing diagnosis is a judgment made only after thorough systematic data collection. Nursing diagnoses describe a continuum of health states, deviations from health, presence of risk factors, and areas of enhanced personal growth. Now let's discuss the status of the nursing diagnosis. It refers to the actuality or potentiality of the problem or syndrome, or the categorization of diagnosis as a health promotion diagnosis. The kinds of nursing diagnoses, according to status, are actual, health promotion, risk, and syndrome. An actual diagnosis is a client problem that is present at the time of the nursing assessment. Examples are ineffective breathing pattern and anxiety. An actual nursing diagnosis is based on the presence of associated signs and symptoms. Next, we have your health promotion diagnosis. It relates to the client's preparedness to implement behaviors to improve their health condition. These diagnosis labels begin with the phrases readiness for enhanced, as in readiness for enhanced nutrition. Next is risk nursing diagnosis. It is a clinical judgment that a problem does not exist, but the presence of risk factors indicates a problem and it is likely to develop unless nurses intervene. For example, all people admitted to the hospital have some possibility of acquiring infection. However, a client with diabetes or a compromised immune system is at higher risk than others. Therefore, the nurse would appropriately use the label risk for infection to describe the client's health status. Next is your syndrome diagnosis. It is assigned by a nurse's clinical judgment to describe a cluster of nursing diagnoses that have similar interventions, such as your risk for disuse syndrome, impaired physical mobility, risk for impaired tissue integrity, and risk for activity intolerance. Now let's proceed to the components of NANDA nursing diagnosis. A nursing diagnosis has three components: the problem and its definition, the etiology, and the defining characteristics. Each component serves a specific purpose. For the problem or diagnostic label and definition, it describes the client's health problem or response for which the nursing therapy is given. It describes the client's health status clearly and concisely. In a few words, the purpose of the diagnostic label is to direct the formation of client's goal and desired outcomes. It may also suggest some nursing interventions. To be clinically useful, diagnostic labels need to be specific. When the word specify follows a NANDA label, the nurse states that the area in which the problem occurs, for example, deficient knowledge on medication or deficient knowledge on dietary adjustments. Qualifiers are words that have been added to some NANDA labels to give additional meaning to the diagnostic statement. Now let's proceed to etiology, related factors and risk factors. The etiology component of nursing diagnosis identifies one or more probable causes of the health problems. It gives direction to the required nursing therapy and enables the nurse to individualize the client's care. Each diagnostic label approved by NANDA carries a definition that clarifies its meaning. Now let's proceed to defining characteristics. Defining characteristics are the cluster of signs and symptoms that indicate the presence of a particular diagnostic label. For actual nursing diagnosis, the defining characteristics are the client's signs and symptoms. For risk nursing diagnosis, no subjective and objective signs are present. Thus, the factors that cause the client to be more vulnerable to the problem form the etiology of a risk nursing diagnosis. So here is an example of your NANDA nursing diagnosis. We have here activity intolerance, insufficient physiological energy to endure desired daily activities. This is your diagnostic label or problem. Related to generalized weakness, This is your etiology, or related factor and risk factor. As manifested by verbal report of fatigue, abnormal heart rate or blood pressure, response to activity, exertion discomfort or dyspnea. This is an example of your defining characteristics. Now let's differentiate the nursing and medical diagnosis. A nursing diagnosis is a statement of nursing judgment and refers to a condition that nurses, by virtue of their education, experience, and expertise, are licensed to treat. On the other hand, medical diagnosis is made by a physician and refers to a condition that only a physician can treat. Medical diagnoses refer to disease processes, specific pathophysiologic responses that are fairly uniform from one client to another. In contrast, nursing diagnoses describe the human response, a client's physical, sociocultural, psychological, and spiritual responses to an illness or a health problem. Now let's proceed to diagnostic process. It uses the critical thinking skills of analysis and synthesis. In critical thinking, a person reviews data and considers explanations before forming an opinion. Analysis is the separation into components, that is, the breaking down of whole into its parts. We call that deductive reasoning. Synthesis is the opposite, that is, the putting together of parts into the whole. This is called your inductive reasoning. The diagnostic process is used continuously by most nurses. An experienced nurse may either enter a client's room and immediately observe significant data and draw conclusions about the client. As a result of attaining knowledge, skill, and expertise in the practice setting, the expert nurse may seem to perform these mental processes automatically. Novice nurses, however, need guidelines to understand and formulate nursing diagnoses. So here is the 3 steps of diagnostic process. First is analyzing data, then identifying health problems, risks, and strengths, and formulating diagnostic statements. First is analyzing data. In the diagnostic process, analyzing involves the following steps. Compare data against the standards. Identify significant cues. Next is cluster the cues, generate tentative hypotheses, and identify gaps and inconsistencies. For experienced nurses, these activities occur continuously rather than sequential. Next is identifying health problems, risks, and strengths. After data are analyzed, the nurse and client can together identify strengths and problems. This is primarily a decision-making process. Next is formulating diagnostic statements. Most nursing diagnoses are written as 2-part or 3-part statements, but there are variations of these. First is 1-part statement. It is applicable for health promotion and syndrome nursing diagnosis. For the health promotion diagnosis, we have readiness for enhanced parenting. And for the syndrome nursing diagnosis, risk for disuse syndrome, impaired physical mobility, risk for impaired tissue integrity, and risk for activity intolerance. Next is the basic 2-part statements. The basic 2-part statement includes the following. Next, we have the basic 2-part statements. The basic 2-part statement includes the following. Problem, which is the statement of the client's response. Etiology. These are factors contributing to or probable causes of the response, and it is recommended for risk nursing diagnosis. The two parts are joined by the words related to rather than due to. The phrase due to implies that one part causes or it is responsible for the other part. By contrast, the phrase related to merely implies a relationship. So we have an example here, risk for infection related to presence of fistula, and anxiety related to threat to physiological integrity, possible cancer diagnosis. Lastly, we have the basic three-part statement. So we have the PES format includes the problem, the etiology, and the signs and symptoms. It is recommended for actual diagnosis and for beginners. Actual nursing diagnoses can be documented by using the three-part statement because the signs and symptoms have been identified. This format cannot be used for risk diagnosis because the client does not have signs and symptoms of the diagnosis. The PES format is especially recommended for beginners because the signs and symptoms validate why the diagnosis was chosen and make the problem statement more descriptive. So here is an example of your three-part statement. Activity intolerance, insufficient physiological energy to endure desired daily activities related to generalized weakness as manifested by verbal report of fatigue, abnormal heart rate or blood pressure response to activity, and exertion discomfort or dyspnea. Now let's proceed to planning, which is the third phase of the nursing process. Planning is a deliberate, systematic phase of the nursing process that involves decision-making and problem-solving. In planning, the nurse refers to the client's assessment data and diagnostic statements for direction in formulating client goals and designing the nursing intervention required to prevent, reduce, or eliminate the client's health problems. A nursing intervention is any treatment based upon clinical judgment and knowledge that a nurse performs to enhance patient or client outcome. And the end product of planning phase is a client care plan. Although planning is basically the nurse's responsibility, input from the client and support persons is essential if a plan is to be effective. Nurses do not plan for the client, but encourage the client to participate actively to the extent possible. In a home setting, the client support people and caregivers are the ones who implement the plan of care. Thus, its effectiveness depends largely on them. Now let's proceed to the types of planning. Planning begins with the first client contact and continues until the nurse-client relationship ends, usually when the client is discharged from the healthcare agency. All planning is multidisciplinary that involves healthcare providers interacting with the client and includes the client and family to the fullest extent possible in every step. So here are the types of planning. First is initial planning, then we have the ongoing planning and the discharge planning. For the initial planning, the nurse who performs the admission assessment usually develops the initial comprehensive plan of care. This nurse has the benefit of seeing the client's body language and can also gather some intuitive kinds of information that are not available solely for the written database. Planning should be initiated as soon as possible after the initial assessment. Next is the ongoing planning. All nurses who work with a client do ongoing planning. As nurses obtain new information and evaluate the client's responses to care, they can individualize the initial care plan further. Ongoing planning also occurs at the beginning of a shift as the nurse plans the care to be given that day. Lastly, we have the discharge planning. It is the process of anticipating and planning for the needs after discharge, and it is crucial part of a comprehensive healthcare plan and should be addressed in each client's care plan. The end product of the planning phase of the nursing process is a formal or informal plan of care. An informal nursing care plan is a strategy for action that exists in the nurse's mind. On the other hand, formal nursing care plan is a written or computerized guide that organizes information about the client's care. And the most obvious benefit of a formal written care plan is that it provides for continuity of care. Your formal care plan is divided into standardized and individualized care plan. A standardized care plan is a formal plan that specifies the nursing care for groups of clients with common needs. All clients with myocardial infarction, for example. On the other hand, individualized care plan is tailored to meet the unique needs of a specific client, needs that are not addressed by the standardized care plan. It is important for all caregivers to work towards the same outcomes, and if available, use approaches shown to be effective with a particular client. Nurses also use the formal care plan for direction about what needs to be documented in client progress notes and as a guide for delegating and assigning staff to care for clients. When nurses use the client's nursing diagnoses to develop goals and nursing interventions, the result is a holistic, individualized plan of care that will meet the client's unique needs. Here are the standardized approaches to care planning. Standardized care plans are pre-developed guides for the nursing care of a client who has a need that arises frequently in the agency. For example, a specific nursing diagnosis or all nursing diagnoses associated with a particular medical condition. They are written from the perspective of what care the client can expect. They should not be confused with standards of care. The standardized approaches to care planning are protocols. These are pre-developed to indicate the actions commonly required for a particular group of clients. For example, an agency may have protocol for admitting a client to the intensive care unit or for caring for a client receiving continuous epidural analgesia. Protocols may include both the primary care provider's orders and nursing interventions. Depending on the agency, protocols may or may not be included in the client's permanent record. We also have policies and procedures. These are developed to govern the handling of frequently occurring situations. For example, a hospital may have policy specifying the number of visitors a client may have. Some policies and procedures are similar to protocols and specify what is to be done, for example, in the case of cardiac arrest. If a policy covers a situation pertinent to client care, it is usually noted on the care plan. For example, making social service referral according to policy manual. Policies are institutional records and do not become a part of the care plan or permanent record. We also have standing order. It is a written document about policies, rules, regulations, or orders regarding client care. Standing orders give nurses the authority to carry out specific actions under certain circumstances, often when a primary care provider is not immediately available. In a hospital critical care unit, a common example is the administration of emergency antiarrhythmic medications when a client's cardiac monitoring pattern changes. In a home care setting, a primary care provider may write a standing order for the nurse to obtain blood tests for a client who has been on a certain therapy for a prescribed amount of time. Regardless of whether care plans are handwritten, computerized, or standardized, nursing care must be individualized to fit the unique needs of each client. Now let's proceed to the formats of nursing care plans. Although formats differ from agency to agency, the care plan is often organized into 4 sections. We have problem or nursing diagnosis, goals or desired outcomes, nursing interventions, and evaluation. Because student care plans are a learning activity as well as a plan of care, they may be more lengthy and detailed than care plans used by working nurse. To help students learn to write care plans, educators may require that more of the plan be original work. They may also modify the plan by adding rationale after the nursing interventions. Rationale mean this is the evidence-based principle given as the reason for selecting a particular nursing intervention. Nurses may also be required to cite supporting literature for their stated rationale. Another method of organizing and representing care plan information is to use a concept map. Concept map is a visual tool in which ideas or data are enclosed in circles or boxes of some shape, and relationships between these are indicated by connecting lines or arrows. Concept maps are creative endeavors. They can take many different forms and encompass various categories of data, according to the creator's interpretation of the client or health condition. Now let's discuss multidisciplinary or collaborative care plans. It is a standardized plan that outlines the care required for clients with common, predictable, usually medical conditions. It includes medical treatments to be performed by other healthcare providers as well. Now let's discuss the planning process. In the process of developing client care plans, the nurse engages in the following activities. We have setting priorities, establishing client goals or desired outcomes, selecting nursing interventions and activities, and writing individualized nursing interventions on care plans. Now let's proceed to priority setting. It is the process of establishing a preferential sequence of addressing nursing diagnoses and interventions. The nurse and client begin planning by deciding which nursing diagnosis requires attention first, which second, and so on. Instead of rank ordering diagnoses, nurses can group them as having high, medium, or low priority. Life-threatening problems such as impaired respiratory or cardiac function are designated as high priority. Now let's move to establishing client goals or desired outcomes. After establishing priorities, the nurse and client set goals for each nursing diagnosis. On a care plan, the goals or desired outcomes describe in terms of observable client responses what the nurse hopes to achieve by implementing the nursing interventions. Here we have the patient outcome criteria or goals. The desired result of the nursing care, that which you hope to achieve with your patient, designed to prevent, remedy, and lessen the problem identified in the nursing diagnosis. So here are the components of the outcome criteria. So outcome statement includes patient behavior, criteria performance, condition, and time frame. So how to set your goals? Outcome statement means it tells the nurse and the patient where they are going. So we should apply the SMART principle in setting your goals or making your goals. S for specific, M measurable, A attainable, R realistic, T time-bound, and H humane. For the patient behavior, this is an observable activity that the patient will demonstrate at some time in the future, showing improvement in the problem area. Examples are: within 8 hours of nursing and medical intervention, the patient will verbalize adequate relief of pain. So this refers for the rest and comfort problem. Next, we have exhibit normal voiding. This refers to the problem with elimination. Also, we have show a decrease in weight for a nutrition problem. Next, we have the criteria performance. This is a standard for the patient behavior outcome, the level at which patient will inform behavior. Examples are at a level of 4 or less, based on the 0 to 10 pain rating scale. Next, at least 30 ml per hour urine, and at least 5 pounds. Condition means it can be thought as specific aids that will help the patient perform a behavior. Examples are with the help of analgesics, with the use of medication, and with exercise. Next is time frame. To clarify how long it would realistically take for the patient to reach the level of functioning. We have intermediate outcome, short-term or specific. It identifies behavior a patient can achieve fairly quickly in a matter of hours, in an 8-hour shift or on a daily basis. Examples are pain to be rated 4 or less within 30 minutes. Also, return of bowel sounds within 12 hours post-operative, and temperature to be below 37.8 degrees Celsius within 1 hour. We also have long-term or final outcome or general. It gives direction for the nursing care over time. Examples are self-care of colostomy 1 month after surgery. Also, re-establishment of patient's usual bowel elimination pattern in 2 months. These are the examples of your patient behavior, criteria performance, condition, time frame in a sentence form. First, the patient will verbalize relief of pain, a level of 4 or less, based on 0 to 10 pain rating scale with the use of analgesics every 4 hours, PRN, during 24 hours post-op. Another outcome statement is the patient will exhibit normal voiding, at least 30 ml per hour urine after removal of Foley catheter. In this statement, condition was not stated. The third outcome statement is the patient will ambulate length of haul and back with the use of walker twice daily. And lastly, we have the patient will demonstrate clear breath sounds on auscultation after 24 hours. Now let's proceed to the nursing outcome classification. Standardized or common nursing language is required in all phases of the nursing process if nursing data are to be included in computerized databases that are analyzed and used in nursing practice. Nurse leaders and researchers have been working since 1991 to develop a taxonomy called the Nursing Outcome Classification, or NOC. This is used for describing clients' outcome that respond to nursing interventions. Next, we have the purpose of goals or desired outcomes. Although goals and outcomes are not necessarily the same concept, the terms are used by some people interchangeably. If reference to NOC, Goals are considered to be met or not met, while progress towards outcome can be described along a continuum in a comparison to previous status. Goals and desired outcomes serves the following: provide direction for planning nursing interventions, serve as criteria for evaluating client progress, enable the client and nurse to determine when the problem has been solved, and help motivate the client and nurse by providing a sense of achievement. Goals may be short-term or long-term. A short-term goal might be client will raise right arm to shoulder height by Friday. In the same context, a long-term goal or outcome might be client will regain full use of right arm in 6 weeks. Short-term goals are useful for clients who require healthcare for a short time or are frustrated by long-term goals that seem difficult to attain and who need satisfaction of achieving a short-term goal. In an acute care setting, much of the nurse's time is spent on the client's immediate needs, so most goals are short-term. However, clients in acute care settings also need long-term goals or outcomes to guide planning for their discharge to long-term agencies or home care, especially in a managed care environment. Outcomes are often set for clients who live at home and have chronic health problems, and for clients in nursing homes, extended care facilities, and rehabilitation centers. Now let's proceed to selecting nursing interventions and activities. Nursing interventions and activities are the actions that a nurse performs to achieve client goals. The specific interventions chosen should focus on eliminating or reducing the etiology of the nursing diagnosis, which is the second clause of the diagnostic statement. So here are the types of the nursing interventions. We have independent interventions, dependent interventions, and collaborative interventions. For the independent interventions, these are activities that nurses are licensed to initiate on the basis of their knowledge and skills. They include physical care, ongoing assessment, emotional support and comfort, teaching, counseling, environmental management, and making referrals to other healthcare professionals. We also have the dependent interventions. These are activities carried out under the orders or supervisions of a licensed physician or other healthcare provider authorized to write orders to nurses. Primary care providers' orders commonly direct the nurse to provide medications, intravenous therapy, diagnostic tests, treatments, diet, and activity. Lastly, we have collaborative interventions. These are actions the nurse carries out in collaboration with the other health team members, such as physical therapists, social workers, dietitians, and primary care providers. Collaborative nursing activities reflect the overlapping responsibilities of and collegial relationship among health personnel. For example, the primary care provider might order physical therapy to teach the client crutch walking. The nurse would be responsible for informing the physical therapy department and for coordinating the client's care to include the physical therapy sessions. The nurse may assist with crutch walking and collaborate with the physical therapy to evaluate the client's progress. The amount of time the nurse spends in an independent versus a collaborative or dependent role varies according to the clinical area, type of institution, and specific position of the nurse. Now let's proceed to writing individualized nursing interventions. After choosing the appropriate nursing interventions, the nurse writes them on a care plan. Date nursing interventions on the care plan when they are written and review regularly at intervals that depends on the individual's need. In an intensive care unit, for example, the plan of care will be continually monitored and revised. In a community clinic, weekly or bi-weekly reviews may be indicated. In addition to the efforts of NANDA to standardize the language for describing problems that require nursing care and to create a taxonomy of standardized client outcome labels, nurse researchers also recognized the need for standardized language to describe the interventions the nurse perform. A taxonomy of nursing intervention, referred to as the Nursing Intervention Classification or NIC, was established. It is a taxonomy of nursing intervention that have been linked to the NANDA nursing diagnostic labels, and each broadly stated intervention includes a label or a name, a definition, and a list of activities that outlines the key action of the nurses in carrying out the intervention. Now let's discuss implementing, which is the fourth phase in the nursing process. Implementing is the action phase in which the nurse performs the nursing interventions. Using the nursing interventions classification terminology, implementing consists of doing and documenting the activities that are the specific nursing actions needed to carry out the interventions. The nurse performs or delegates the nursing activities for the interventions that were developed in the planning step and then concludes the implementing step by recording nursing activities and the resulting client responses. To implement the care plan successfully, nurses need cognitive, interpersonal, and technical skills. These skills are distinct from one another. In practice, however, nurses use them in various combinations with different emphasis depending on the activity. For example, when inserting a urinary catheter, the nurse needs cognitive knowledge of the principles and steps of the procedure, interpersonal skills to inform and reassure the client, and technical skills in draping the client and manipulating the equipment. For the cognitive skills, it is also known as intellectual skills. It includes problem solving, decision making, critical thinking, clinical reasoning, and creativity. And they are crucial to safe, intelligent nursing care. For the interpersonal skills, these are all of the activities, verbal and nonverbal, people use when interacting directly with one another. The effectiveness of a nursing action often depends largely on the nurse's ability to communicate with others. The nurse uses therapeutic communication to understand the client and in return be understood. A nurse also needs to work effectively with others as a member of the healthcare team. Interpersonal skills are necessary for all nursing activities. Caring, comforting, advocating, referring, counseling, and supporting are just a few. Interpersonal skills include conveying knowledge, attitudes, feelings, interest, and appreciation of the client's cultural values and lifestyle. Before nurses can be highly skilled in interpersonal relations, they must have self-awareness and sensitivity to others. Lastly, we have technical skills. These are purposeful hands-on skills such as manipulating equipment, giving injections, bandaging, moving, lifting, and repositioning clients. These skills are also called tasks, procedures, or psychomotor skills. The term psychomotor refers to physical actions that are controlled by the mind, not by reflexes. Technical skills require knowledge and frequently manual dexterity. The number of technical skills expected of a nurse has greatly increased in recent years because of the pervasive use of technology, especially in acute care hospitals. Now let's proceed to the process of implementing. The process of implementing normally includes the following: reassessing the client, determining the nurse's need for assistance, implementing the nursing interventions, supervising the delegated care, and lastly, documenting nursing activities. Now let's proceed to evaluating, which is the last phase of the nursing process. To evaluate is to judge or to appraise. Evaluating is the fifth phase and last phase of the nursing process. In this context, evaluating is a planned, ongoing, purposeful activity in which clients and healthcare professionals determine the client's progress towards achievement of goals or outcomes and the effectiveness of the nursing care. Evaluation is an important aspect of the nursing process because conclusions drawn from the evaluation determine whether the nursing interventions should be terminated, continued, or changed. Now let's proceed to the 5 components of evaluation phase. First is collecting data related to the desired outcomes. Next is comparing data with desired outcomes. Next is relating nursing activities to outcomes and drawing conclusions about problem status, and lastly, continuing or modifying or terminating the nursing care plan. For the evaluation statement, after determining whether or not a goal has been met, the nurse writes an evaluation statement either on the care plan or in the nurse's notes. An evaluation statement consists of 2 parts, a conclusion and supporting data. The conclusion is a statement that the goal or desired outcome was met, partially met, or not met. The supporting data are the list of clients' responses that support the conclusion. Now let's discuss evaluating the quality of nursing care. In addition to evaluating goal achievement for individual clients, nurses are also involved in evaluating and modifying the overall quality of care given to the groups of clients. It is an essential part of the professional accountability. Nurses and all other healthcare providers work together as an interprofessional team focused on improving client care. The activities both use and contribute to evidence-based practice. Quality Assurance Program is an ongoing systematic process designed to evaluate and promote excellence in the healthcare provided to clients. Quality assurance frequently refers to evaluation of the level of care provided in a healthcare agency, but it may be limited to the evaluation of the performance of one nurse or more broadly involve the evaluation of quality of the care in an agency or even in a country. Quality assurance requires evaluation of 3 components of care. We have structure evaluation, process evaluation, and outcome evaluation. Each type of the evaluation requires different criteria and methods, and each has different focus. For structure evaluation, it focuses on the setting in which care is given. It answers this question: what effect does the setting have on the quality of care? Structural standards describe desirable environmental and organizational characteristics that influence care, such as equipment and staffing. For the process evaluation, it focuses on how the care was given. It answers questions such as: is the care relevant to the client's needs? Is the care appropriate, complete, and timely? Process standards focus on the manner in which the nurse uses the nursing process. Some examples of process criteria are: checks client's identification band before giving medication, and performs and records chest assessment, including auscultation once per shift. For the outcome evaluation, it focuses on demonstrable changes in the client's health status as a result of nursing care. Outcome criteria are written in terms of client's responses or health status, just as they are for evaluation within the nursing process. For example, how many clients undergoing hip repairs develop pneumonia? Or how many clients who have a colostomy experience an infection that delays discharge? Now let's proceed to quality improvement. Serious national efforts are currently underway to evaluate and improve the quality of healthcare based on internal assessment by healthcare providers and increasing awareness by the public that medical errors are not uncommon and can be lethal. Quality improvement follows client care rather than organizational structure, focuses on process rather than individuals. It also uses a systematic approach with the intention of improving the quality of care rather than ensuring the quality of care. Now let's proceed to sentinel events. These are unexpected occurrence involving death or serious physical or psychological injury or the risk thereof. Serious injury specifically includes loss of limb or function. The phrase or the risk thereof includes any process variation for which a recurrence would carry a significant chance of a serious adverse outcome. Such events are called sentinel because they signal the need for immediate investigation and response. What is root cause analysis? It is a process for identifying the factors that bring about deviations in practices that lead to the event. It focuses primarily on system and processes, not individual performance. It begins with examination of the single event, but with the purpose of determining which organizational improvements are needed to decrease the likelihood of such events occurring again. Now let's proceed to nursing audit. Audit refers to the examination or review of records. A retrospective audit is the evaluation of a client's record after discharge from an agency. However, concurrent audit, the evaluation of a client's healthcare while the client is still receiving care from the agency. These evaluations use interviewing, direct observation of nursing care, and review of clinical records to determine whether specific evaluative criteria have been met. Another type of evaluation of care is the peer review. In a nurse peer review, nurses functioning in the same capacity, that is, peers appraise the quality of care or practice performed by other equally qualified nurses. The peer review is based on pre-established standards or criteria. There are two types of peer review. We have individual audit and nursing audit. Individual audit focuses on the performance of an individual nurse. On the other hand, nursing audit focuses on evaluating nursing care through the review of records. The success of these audits depends on accurate documentation. I believe this is the end of our topic on the nursing process. Thank you so much for listening.